Welcome to the deep dive. Ever wonder how that incredibly complex network, the arteries, veins, even those lymphatic vessels in your body, actually got there?
It's quite the origin story.
Yeah. Today, we're diving into the blueprint. We've got this document, 002 Embryology and Developmental Anatomy.pdf, and we're going to uncover the, well, surprisingly intricate beginnings of our internal plumbing.
Right, and think of it less like snapping together building blocks and more like a biological orchestra playing out over time.
I like that. So we're exploring these key stages.
Exactly. Not just to, marvel at it all, but to really understand why these early steps are so crucial. And crucially, how they sometimes lead to the variations we see later on.
Okay, let's unpack that. Our mission here isn't to drown you in every single microscopic detail, right?
No, definitely not.
We want to pull out the really key moments, the big milestones in forming these vital transport systems. Shed some light on just how early this all kicks off, and maybe touch on why knowing this stuff matters, especially when things don't go quite to plan.
Absolutely. For anyone in the medical field, understanding these developmental roots is, well, it's like knowing the backstory. It gives you vital clues about why certain vascular anomalies pop up.
Connecting the dots from embryo to clinic.
Precisely. Those early events directly link to what doctors might see down the line.
So let's rewind. Way back. First few weeks, the embryo is tiny. How does it get by?
Yeah, for the first, say, 3 weeks, it's so small that simple diffusion works just fine.
Like substances just soaking through.
Pretty much. Oxygen, nutrients in, waste out. Passive, simple.
But that system has its limits, I guess. Can't scale up.
Exactly right. As the embryo starts growing and it grows fast, diffusion just can't cut it anymore. The distances become too great.
Makes sense.
So by the 4th week, you absolutely need a functional cardiovascular system. It's non-negotiable. In fact, it's one of the very first major systems to develop and actually start working.
Wow, that early. So what are the absolute first signs, the first little sparks of this system?
Around day 17, you start seeing these little isolated clusters, blood islands they're called, forming in the yolk sac. That's outside the embryo proper.
Providing early fuel.
Yeah. Then just a day later, maybe day 18, similar vessels start appearing within the embryo itself.
And the heartbeat. When does that kick in?
Remarkably early. By day 22, the primitive heart tube starts to beat. And by day 24, it's actually pumping blood.
Day 24. That's incredible progress in just a few days. So how do these first vessels actually form? You mentioned two key ways.
That's right, vasculogenesis and angiogenesis. Think of them as building the initial roads versus expanding the road network later on.
Okay, let's start with vasculogenesis, the initial road building. What's the gist there?
Vasculogenesis is essentially creating blood vessels completely from scratch, de novo.
From nothing.
Well, from precursor cells. Starts with these specific cells in the mesoderm layer, splanchnic mesodermal cells. They transform into angioblasts.
Angioblasts, okay.
These are like the founder cells for the vessel lining, the endothelium. They clump together into little vesicles, little bubbles, within that mesoderm layer, both inside and outside the embryo.
So these clumps are the absolute seeds.
You got it. The angioblasts then flatten out, become endothelial cells, and organize themselves into these small cords, like strings of pearls almost.
And these strings connect up.
Exactly. They coalesce, they merge, and form a primitive capillary plexus. Very basic, tangled network of tiny vessels.
And what's driving this? What's the signal?
A really important protein signal called VEGF, vascular endothelial growth factor.
VEGF. Heard of that one?
Yeah, it's the main conductor here, orchestrating this initial formation. And importantly, vasculogenesis is mostly an embryonic thing. It lays down the main highways, but it doesn't happen much later in life.
Okay, so that's the foundation. Now, angiogenesis, expanding the network. How does that work?
Angiogenesis is making new vessels by sprouting or budding off from ones that already exist.
Like branches growing off a tree.
Perfect analogy. It happens because the growing embryo needs more supply lines, more oxygen, more nutrients.
So what triggers the sprouting?
Often it's tissues that are running low on oxygen, hypoxic tissues.
Ah, okay.
They release signals like HIF-1, a hypoxia-inducible factor, and also VEGF again. These signals basically tell the existing endothelial cells, hey, send out some sprouts over here.
A demand-driven system. Need more roads.
Exactly. And these new capillary networks aren't static. They get remodeled constantly. They differentiate into arteries, capillaries, veins. It all depends on the local environment, the flow, the signals.
And this process can happen later in life.
Yes, absolutely. Angiogenesis occurs throughout development, but also in adults. Think about wound healing or tissues recovering from ischemia, lack of blood flow. That requires angiogenesis.
Right. Okay, so you get arteries, veins, but how does the embryo know which is which, especially before blood is even flowing properly?
That's a fantastic question. It shows just how precise this is. The fate of a vessel artery or vein is decided very early on, before significant flow. It comes down to specific molecular markers on the cell surface. Proteins. EP2 is the I'm an artery signal, and EPV4 is the I'm a vein signal.
Molecular labels. And how do
Yeah.
they get switched on or off?
It's a cool little signaling cascade. For arteries, VEGF binds its receptor, VEGFR2. This turns on a pathway called Notch signaling.
Okay.
Notch then suppresses another protein called QUPTFII, and that suppression allows the AF2 artery marker to be expressed.
Right, step by step. And for veins?
It's kind of the opposite. CUPTFII is active, and it suppresses Notch signaling. This leads to the expression of the EP4 vein marker. It's like a molecular switch determined by which signal wins out.
A molecular toggle switch. Fascinating. What about the third system, the lymphatics? How do they fit in?
Lymphatic development involves different key players, mainly proteins called SOX18 and PROX1.
PROX1.
Yeah, phosphoryl transcription factor 1. Interestingly, PROX1 actually partners up with QPTFII, the vein signal guy.
Oh, okay, teamwork.
Sort of. This PROX1QTFII complex promotes the expression of another VEGF receptor, VEGFR3. And activating VEGFR3 is what really kicks off the development of the lymphatic system.
So they're all linked at the molecular level, even if their jobs are different?
Precisely. Arteries, veins, lymphatics, their development is orchestrated together.
So we've got vasculogenesis laying down the main pipes, angiogenesis expanding. How does the heart's development tie into all this shaping?
Huge influence. While vasculogenesis sets up the major vessels, the heart tube, the dorsal aortas, the big veins like umbilical and vitelline, it's angiogenesis and another process called intussusception, called like vessel splitting, that really refine the network.
And the heart itself is moving and changing shape.
Oh yeah. Around day 20, the developing neural tube, the future brain and spinal cord, grows rapidly. This growth actually pushes the heart-forming region, the cardiogenic area, downwards and forwards, ventrally and caudally.
Towards the chest location.
Exactly. And at the same time, the embryo folds side to side, laterally. This folding brings the two initial heart tubes, the endocardial tubes, together in the midline, and they fuse.
Into one single tube?
To start with, yes. A single tube with an outflow end pointing towards the head and an inflow end towards the tail.
Doesn't sound like a four-chambered heart yet.
Not at all. But this tube then elongates and develops distinct swellings or segments. From inflow to outflow, you get the sinus venuses, then the primitive atrium, the primitive ventricle, the bulbus cordus.
Which becomes the right ventricle.
Right. And finally, the truncus arteriosus at the outflow end.
Okay.
And a little dilation at the very end of the truncus, the aortic sac, connects this primitive heart to those dorsal aortas running along the back.
A lot of action in a tiny space.
Definitely. And as the heart moves ventrally between days 22 and 24, those dorsal aortas get pulled into a curve, forming the very first aortic arch.
The start of the big arteries branching off the top of the heart?
Exactly. That first arch sits within the first pharyngeal arch, those structures in the developing neck throat region. Then arches 2 through 6 develop sequentially within their own pharyngeal arches between days 26 and 30.
In order.
Yeah, head to tail. Craniocaudal sequence.
What about those dorsal aortas themselves? They start as a pair, right?
They do. But that same lateral folding causes them to fuse together in the midline, from about the mid-chest level downwards. So below that point, you get a single common aorta.
But they stay separate higher up towards the head.
That's right. They remain paired rostrally. And by the start of week 4, little arteries start sprouting off these dorsal aortas between the body segments, the somites. These are the intersegmental arteries.
Feeding the segments.
Yep. They have branches going dorsally to the back, laterally and ventrally to the body wall, setting up the segmental supply pattern.
Okay, so the basic highway system is roughed out. Let's zoom in on those aortic arches. It sounds like a real hotspot for developmental changes. And maybe things going wrong.
Absolutely. The aortic arch system is critical. It forms the main arteries to the head, neck, and arms. It starts as 6 pairs of arteries branching off that aortic sac, connecting to the dorsal aortas.
6 pairs.
But here's the key.
Yeah.
They aren't all there at once. The early ones regress as the later ones form. It's dynamic, constant remodeling.
So it's not just adding, it's subtracting too. Sculpting.
Exactly. The first and second arches, they appear, then disappear pretty quickly. Don't contribute much to the adult pattern. And the 5th arch, well, It's usually rudimentary or it doesn't form at all in humans.
Skip number 5. Okay. What about the third arches?
The third arches are important. They become the common carotid arteries feeding the head and neck, and the very first part, the proximal part, of the internal carotid arteries going to the brain.
And the rest of the internal carotid.
That comes from the dorsal aorta section between arches 1 and 3.
Hmm.
The external carotids, for the face and scalp, they actually sprout off the common carotids later.
Right.
And critically, the piece of dorsal aorta between the third and fourth arches on each side disappears. That helps direct blood flow up through the third arch system to the head, like closing an unnecessary connecting road.
Got it. Now, the fourth arches, different fates on left and right.
Correct. The left fourth arch becomes a major piece of the adult aortic arch itself,
Mm-hmm.
the segment between the left common carotid and the left subclavian artery origin.
The main curve.
Part of it, yeah. The right fourth arch, though, forms only the very beginning, the proximal part, of the right subclavian artery supplying the right arm.
So where does the rest of the right subclavian come from?
It forms from the right dorsal aorta further down, plus the right seventh intersegmental artery, and the bit of right dorsal aorta beyond that seventh intersegmental connection that normally involutes disappears.
Okay. That leaves the sixth arches. They're connected to the lungs, right? Pulmonary system.
Exactly. The proximal parts closer to the heart of both sixth arches become the pulmonary arteries.
Left and right pulmonary arteries.
Yep. Now, the distal parts are different. The distal right sixth arch disappears completely, but the distal left sixth arch persists during fetal life as the ductus arteriosus.
The fetal shunt.
The very one.
Yeah.
It shunts blood from the pulmonary artery directly into the aorta, bypassing the lungs, which aren't breathing air yet.
And after birth.
Normally, it closes off rapidly as the baby starts breathing. It becomes a fibrous cord, the ligamentum arteriosum, a closed bypass.
Wow. Okay, with all that complex choreography appearing, disappearing, fusing, sprouting, it seems almost inevitable that variations or anomalies would happen.
It's true. Variations are quite common. That textbook normal pattern we just described, maybe only in 65% of people.
Really? That low?
Yep. One of the most common variations is the so-called bovine arch, seen in maybe 15 to 30% of people.
Bovine arch?
Yeah, this is where the left common carotid artery originates from the brachiocephalic trunk, that first big branch off the arch, instead of directly from the arch itself.
Oh,
It's just a different branching pattern. Usually no big deal.
okay. Any others?
Oh, lots of minor ones. Shortened brachiocephalic, left vertebral artery coming off the arch, each less than 3% prevalence.
But then there are the ones with more serious implications, like patent ductus arteriosus, PDA.
Right. If that ductus arteriosus from the left sixth arch fails to close after birth, you get PDA. Blood shunts the wrong way from the high-pressure aorta back into the pulmonary artery.
Straining the lungs and heart.
Exactly. Can lead to pulmonary hypertension. It's more common in premature babies whose closure mechanisms might just not be ready yet.
And coarctation of the aorta. That sounds serious, too. A narrowing.
Yes. Coarctation is a congenital narrowing of the aorta. It often happens near where the ductus arteriosus was, or is. Postductal, just after the ligament, is common. Preductal, before it, also occurs.
Why does it happen?
The thought is maybe some ductal tissue gets incorporated into the aortic wall during development, and then it constricts after birth. In postductal cases, the body often develops collateral vessels, detours, to get blood past the narrowing. You can sometimes see evidence of these on X-rays as rib notching.
Wow. Preductal often stays open.
The ductus often stays open in preductal coarctation to maintain blood flow to the lower body.
Double aortic arch, that sounds like it could cause physical problems, like a ring.
It does form a ring. It happens if the right dorsal aorta, the part that should disappear after the right subclavian takeoff, persists. So you have two arches circling the esophagus and trachea.
Squeezing them.
Can do, yes, leading to trouble swallowing or breathing, like a vascular collar that's too tight.
And a right aortic arch? Is that just a mirror image?
Sometimes. It means the main arch curves right instead of left, because the left dorsal aorta involuted instead of the right. If it passes behind the esophagus and there's an aberrant left subclavian artery, it can also form a ring.
But sometimes it doesn't form a ring.
Right. If it passes in front mirror image branching, no ring. But that pattern is linked to a slightly higher risk of other heart defects.
Okay, one more common one mentioned is the aberrant right subclavian artery, taking a weird path.
Yeah, ARSA. This happens if the right subclavian forms abnormally, usually from the dorsal aorta further down and more to the left. It ends up being the last branch off the arch arising from the left side.
So it has to cross over.
Exactly. It usually passes behind the esophagus to get to the right arm. Most people have no symptoms, but maybe 5% get dysphagia, leukorrhea, trouble swallowing because of that pressure.
And aneurysms.
Yeah, that spot where it originates can sometimes dilate into an aneurysm called a comoral diverticulum, which can cause its own problems.
And lastly, carotid artery anomalies, less common.
Much rarer. Things like a genesis absence or aplasia, underdevelopment of the carotids, or sometimes the internal carotid takes an unusual pass behind the pharynx, which is really important for surgeons to know about for things like tonsillectomies.
It's absolutely staggering, the precision required and the potential for variation. Okay, let's move down the body. The descending aorta, the main pipeline south, how does that form?
The descending aorta, below the arches, forms from that fusion of the paired dorsal aortas in the fourth week.
The part that fuses.
Right. And as it forms, it sends out those segmental arteries at each body segment level. Dorsal branches for the spine and back muscles, ventral branches for the body wall muscles, lateral branches for other stuff.
And these segmental arteries become the arteries we know, like intercostals.
Many do, yeah, through connections and anastomoses and some parts disappearing. In the neck, dorsal branches link up to form the vertebral arteries. In the chest, they become intercostals. Ventral branches contribute to thoracic arteries supplying the chest wall.
And lower down, lumbar region.
Dorsal branches become lumbar arteries. The fifth lumbar pair is key. They give rise to the common iliac arteries for the legs. Ventral branches down there initially form the umbilical arteries.
Going to the placenta.
Right, and also the vitelline arteries supplying the early gut and yolk sac.
So the umbilical arteries are actually modified embryonic vessels.
Yeah, their base connects to the fifth lumbar intersegmentals. After birth, the parts closest to the aorta fade away, and the more distal bits become the internal iliac arteries supplying the pelvis.
And those vitelline arteries feeding the gut.
As the gut tube develops, these vitelline arteries consolidate and remodel to become the three main unpaired arteries supplying the digestive tract. The celiac artery for the foregut, stomach, liver, superior mesenteric for the midgut, small intestine, and inferior mesenteric for the hindgut, large intestine.
What about those lateral branches off the aorta?
They mostly supply the developing urogenital system, kidneys, and gonads. The adult kidney, the metanephros, actually connects to several of these initially.
And then chooses one.
Usually it narrows down, with several fusing to form the final renal artery or arteries. This explains why variations in renal artery number are so common. Horseshoe kidneys or ectopic kidneys almost always have multiple renal arteries because of this complex origin.
Makes sense.
Other lateral branches become the adrenal arteries and the gonadal arteries, testicular or ovarian.
Okay, down to the limbs. Arms and legs budding off. How do they get their blood supply wired up?
Right, the limb buds grow out from the trunk. There's a special ridge of cells at the tip, the apical ectodermal ridge, guiding growth. Tissues form sequentially. Skeleton first, then muscle, then nerves grow in, and then the blood vessels arrive.
Where do the vessels come from?
Some grow in from those segmental arteries and major veins, but also angioblasts pop up right there within the limb bud mesenchyme.
So a mix of incoming and local building.
Exactly. You initially get this dense capillary mesh, like netting. Then, through remodeling, one central artery usually becomes dominant.
The main pipeline for the limb.
Yeah. Blood flows out through that into peripheral capillaries and then collects in a vein at the edge, the marginal sinus.
Let's do the upper limb, the arm, first. What's the initial main artery?
The supply comes from the seventh cervical intersegmental artery, which connects to an axial artery running down the core of the limb bud.
And that axial artery becomes?
It becomes a brachial artery in the upper arm and the anterior interosseous artery in the forearm. Part of it also sticks around in the hand, contributing to the deep palmar arch.
But we have radial and ulnar arteries, too.
They sprout later, off the brachial. As they grow, they take over the main forearm supply, and that interosseous artery becomes less important. In the hand, the radial and ulnar become dominant. The median artery, which can be significant early on, usually regresses after about 8 weeks.
Any common variations up here?
A few. A high origin of the radial artery, branching off higher up the arm near the elbow, happens in maybe 14% of people.
Okay.
And sometimes that median artery persists significantly down into the palm, maybe in up to 12%. But major anomalies in the upper arm itself are less common.
Now, the lower limb, the leg, sounded more complicated in the source.
It is a bit more complex. The umbilical arteries initially connect to the fifth lumbar intersegmentals, forming the common iliacs. The external iliac branches off and runs down as the iliofemoral artery into the thigh.
But there's another player, the sciatic artery.
Yes. Initially, the main supply to the early leg is actually the sciatic artery, an extension of the internal iliac. It follows the sciatic nerve, It meets the iliofemoral system down near the knee.
And then it disappears.
Mostly, yes. By about week 8, it regresses significantly. Parts of it persist is the popliteal artery behind the knee and the peroneal artery in the lower leg. But the main highway becomes the external iliac femoral system.
So a developmental handover.
Pretty much.
Hmm.
Even the popliteal artery formation is complex, involving the fusion of parts of the sciatic system, deep popliteal, and the iliofemoral system, superficial popliteal, with bits regressing to get the final configuration behind the knee.
And predictably, anomalies can happen here too. Persistent sciatic artery.
Right. If that iliofemoral system doesn't develop properly, the sciatic artery can stick around as the main vessel to the thigh or even the whole lower leg. It's rare, maybe 0.05%.
What are the implications?
Clinically, you might find a weak or absent femoral pulse, but a normal popliteal pulse.
Right.
Because it runs superficially in the buttock, it's prone to injury, early atherosclerosis, and aneurysm formation, which can then compress the actual sciatic nerve.
Ouch! Popliteal artery entrapment syndrome, that sounds different. Not a developmental error in the vessel itself.
More about its relationship with the surrounding muscles. Slight variations in how the calf muscles, like the gastrocnemius, develop or position themselves can lead to the popliteal artery getting squeezed or compressed during exercise.
Causing pain.
Yeah,
Yeah.
typically claudication pain with exercise in young athletic people. It can also lead to aneurysms from the repeated trauma.
And finally, variations down in the lower leg arteries. Tibial arteries.
Oh yeah, those are pretty common, around 10%. Things like a hypoplastic, small, or absent posterior tibial artery, the anterior tibial artery branching off really high up the
A
popliteal.
high origin.
Right, or even all three main branches, anterior tibial, posterior tibial, peroneal, coming off at the same point, a trifurcation. These variations are often bilateral, same on both legs.
Knowing these must be important for surgeons working on the leg.
Absolutely critical for vascular procedures or even some orthopedic surgeries.
Okay, arteries done. Let's switch to the return trip, the venous system. You mentioned earlier it might be even more variable than the arteries. Why is that?
Yeah, the veins start out as more diffuse networks, more plexiform. There are initially more potential channels available, so as the system matures and consolidates, there's just more opportunity for different routes to persist or regress, leading to more anatomical variation.
Makes sense. More initial options.
By week 4, these early networks start enlarging into definitive veins. And initially, there are 3 main paired systems feeding into the early heart.
Which are?
The vitelline veins, draining the yolk sac and gut, the umbilical veins, carrying oxygenated blood from the placenta, and the cardinal veins, draining the embryo itself.
Let's take vitelline first. Gut drainage. What do they become?
They run from the yolk sac towards the heart, passing through the developing liver. They form a dense network in the liver, the hepatic sinusoids.
Liver blood channels.
Right. Then the left vitelline mostly regresses. Blood gets shunted over to the enlarged right vitelline vein as it traverses the liver. Part of this right vitelline within the liver becomes the ductus venosus.
The liver bypass shunt again.
Exactly, connecting to the IVC.
Yeah.
The part of the right vitelline above the liver becomes the very top part of the inferior vena cava, IVC. And the part below the liver forms the portal vein and the superior mesenteric vein, major components of the gut drainage system.
Wow. Okay, umbilical veins, oxygen from mom.
Yep, oxygenated blood from placenta to fetus. Initially paired, but the right one disappears early. The left umbilical vein persists.
And it connects to...
It connects directly into that ductus venosus in the liver, again allowing oxygen-rich blood to bypass much of the liver circulation and get to the heart and brain quickly.
And after birth, when the cord is cut?
The left umbilical vein closes off, becomes the ligamentum teres, that round ligament in the falciform ligament of the liver, and the ductus venosus closes, becomes the ligamentum venosum, fibrous remnants.
Okay, that leaves the cardinal veins, draining the embryo itself, the main blueprint.
Pretty much. You have anterior cardinals draining the head end and posterior cardinals draining the tail end. They meet to form short common cardinal veins that dump into the sinus venuses of the heart.
And these give rise to the major veins we know, SVC and IVC.
The anterior cardinals are the basis for the superior vena cava, SVC, and its tributaries jugulars, subclavians. The posterior cardinals, plus 2 later sets of veins called subcardinal and supracardinal veins, all contribute in a complex way to the inferior vena cava, IDC, the azygos system, and veins like the renal and gonadal veins.
Let's tackle the SVC first. Upper body drainage. How do the anterior cardinals form that?
The headward parts of the anterior cardinals become the internal jugular veins. They connect to external jugulars from the face. Subclavian veins draining the arms connect and lower down.
Right.
Then, around week 7, a crucial bridge forms an anastomosis between the left and right anterior cardinals. This bridge becomes the left brachiocephalic vein.
Shunting blood across.
Exactly. It allows blood from the left head and arm to cross over to the right side. After this forms, the part of the left anterior cardinal below this bridge usually regresses.
Leaving the right side dominant.
Right. The SVC itself forms from the enlargement of a right anterior cardinal vein and the right common cardinal vein. The little bit of the left common cardinal that persists becomes the coronary sinus, draining the heart muscle itself.
Any common SVC anomalies?
Yeah, you can get a double SVC if that lower left anterior cardinal fails to regress, or a left-sided SVC if the right one regresses instead and the left persists as the main channel, with the brachiocephalic crossing the other way, usually asymptomatic, just an odd finding on imaging.
Okay, now for the IVC. Lower body. Sounds like a real construction project involving multiple vein systems.
It is incredibly complex. It involves bits of vitelline veins and those 3 sets of cardinal veins, posterior, subcardinal, and supracardinal, with lots of connections and shifts, mainly shunting blood from left to right.
So piece by piece.
The very top bit, just under the heart, comes from that right vitelline vein in the liver. The rest involves those parallel pairs. Posterior cardinals appear first, but mostly regress, except for the very bottom part, which forms the lowest IVC in common iliacs, and the top bit, which forms the root of the azygos vein.
Then subcardinals.
They sprout off the posterior cardinals, drain the early kidneys. They connect across the midline. The right subcardinal enlarges to become the renal segment of the IVC. The connection across becomes the left renal vein. The left subcardinal mostly disappears above this connection, but the part below persists as the left gonadal vein.
Okay, last pair. Supracardinals.
Yep, they appear last, drain the body wall. The right abdominal supracardinal connects to the right subcardinal part to form the infrarenal IVC below the kidneys. It also connects down to the fused posterior cardinals. In the chest, the right supracardinal becomes the azygos vein, and the left becomes the hemiazygos vein after losing direct connection to the heart and connecting across to the right. It's a lot.
It really is, like plumbing rerouted multiple times. And anomalies here too. Double IVC, left IVC.
Exactly. Double IVC if the left supracardinal fails to regress. Left-sided IVC if the right supracardinal regresses instead, creating a mirror image that usually crosses back to the right at the renal vein level.
Yeah.
Important for things like IVC filter placement.
And renal vein anomalies. That retro-aortic left renal vein.
Most common one. The left renal vein normally forms from an anterior connection between subcardinals, while a posterior connection regresses. If the anterior part regresses and the posterior persists, the left renal vein runs behind the aorta.
Retro-aortic.
Right. Or if both persist, you get a circumaortic venous ring around the aorta. Definitely things surgeons need to be aware of during aortic procedures near the kidneys.
Yeah. Okay, last system. Lymphatics. Different job drainage, immunity. How do they develop? Is it also from blood vessels?
That's been the debate. The current thinking, strongly supported, is a dual origin. Some lymphatic endothelial cells do bud off from veins, particularly cardinal veins, but others seem to arise independently from non-venous cells in certain tissues.
So both theories were partly right.
Looks that way. Key molecular players are different too, like PROX1, SOX18, and the VEGF-ZVEGFR3 pathway, not VEGF-AVGFR2 like in blood vessels.
How does the network actually form? Starts with sacs.
Yes, it begins with 6 primary lymph sacs developing between weeks 5 and 6, generally head to tail. 2 jugular sacs near the neck veins, 2 posterior sacs near the iliac veins, an unpaired retroperitoneal sac near the kidneys, and the unpaired cisterna-chyli lower down near the lumbar veins.
And the vessels sprout from these sacs.
Exactly. Lymphatic vessels bud off these sacs, mostly following the paths of the major veins. Extensions go down from the jugular sacs and up from the cisterna-chyli. They meet and fuse in the chest.
Forming the thoracic duct.
Right. The 2 parallel vessels fuse to form the main thoracic duct. The connection from the right jugular sac persists as the smaller right lymphatic duct. Other vessels continue budding off these main trunks.
Do they go everywhere?
Almost. Lymphatics don't typically invade the central nervous system, eye, inner ear, cartilage, epidermis, or spleen.
What happens to the original sacs? And where do lymph nodes come from?
The sacs, except for the top of the cisterna-chyli, get invaded by connective tissue and mesenchymal cells, including immune cell precursors. They remodel into clusters of lymph nodes. The initial broad connections to the veins are mostly lost, leaving only the final drainage points of the thoracic and right lymphatic ducts into the big veins at the base of the neck.
And that dual origin idea, non-venous contribution.
Yeah, studies show, for instance, that some dermal lymphatics in the skin might arise from non-venous sources. So lymphatic endothelial cells likely have mixed origins. Problems here, like failure of dermal lymphatic development, perhaps due to mutations like in SOX18, can lead to hypoplasia and lymphedema.
Lymphedema, swelling due to poor lymphatic drainage.
Exactly. There's research into treatments, but still early days for clinical application.
So it seems like all three systems, arterial, venous, lymphatic, are developing side by side, interacting.
Absolutely. And errors right back in those earliest stages when things are still just messy networks can lead to vascular malformations. Gene mutations affecting vessel identity can cause AVMs or venous malformations. Lymphatic problems can occur alongside or separately.
It really highlights how interconnected it all is.
It does. And understanding these fundamental molecular pathways better is really our best hope for developing new therapies for all sorts of vascular diseases down the road.
It is truly amazing to think about this whole intricate, precisely timed process unfolding so early in life.
It really is. From vasculogenesis and angiogenesis building the pipes to the incredible remodeling of the aortic arches, the complex origins of the veins, the budding of the lymphatics, it's biological engineering at its finest.
And we've seen how even tiny deviations from that plan can lead to this huge range of anatomical variations, some benign, some clinically significant. It just underscores that delicate developmental balance.
Perfectly put. So for you listening, maybe take a moment to consider how this very early development, this foundation, influences health throughout life, often in unseen ways.
Yeah.
And think about how digging deeper into these origins might unlock future treatments. It makes you wonder, doesn't it? What other fundamental processes happening way back then have such profound and lasting consequences for who we are and how well we function?